Welcome to a podcast brought to you by the American Academy of Orthopedic Manual Physical Therapists. Our academy is a national organization committed to excellence in orthopedic manual physical therapy practice, education, and research, and we're here to explore a wide range of topics with you through interviews with content experts.
Hello, everyone. Welcome to another episode of the AMPT podcast. Today, we're joined by Drs. Ruth Chimenti and Andrew Post. Dr. Ruth Chimenti is an assistant professor of physical therapy and rehabilitation science at the University of Iowa. She's received her DPT from Washington University and her PhD from the University of Rochester. Dr. Andrew Post is a PhD student at the University of Iowa, received his DPT at Grand Valley State University, and completed his fellowship training at the University of Illinois at Chicago. Both have extensive clinical experience in the orthopedic outpatient setting and have published extensively on Achilles tendinopathy, including CPG that Dr. Chimenti was a part of. Today, we'll be discussing their recent publication from Pain titled The Effects of Pain Science, Education, plus Exercise on Pain and Function in Chronic Achilles Tendinopathy, a blinded, placebo-controlled, explanatory, randomized control trial. Drs. Chimenti and Post, thanks so much for joining us.
Thank you so much for offering to have us on your program. This will be fun.
Thank you for having us.
So, Dr. Chimenti, for those that haven't read the article or have read it maybe a while ago, can you start by giving our audience a kind of brief recap of what you all did and what you found?
Yeah. So in treating and talking with patients who had Achilles tendinopathy, a lot of times it would come up that they felt like when they had this pain in their tendon, that they were worried that this was a sign of impending rupture, or they had seen these bone spurs on x-ray and they understood this to be the primary source of their pain. And since exercise can't remove bone, could physical therapy really help them? And so we saw these pain beliefs as potential barriers to engaging in an exercise program and maximizing the benefits from it. And so we hypothesized that designing a pain education program that addressed these fears and pain beliefs would result in better outcomes in terms of pain and function. And the way that we tested this is we brought people in who had chronic Achilles tendinopathy pain, and we did some baseline measures, and then they were randomized to either get a pain science education or a more pathoanatomic focused education. And then they had 6 to 7 treatment visits with a physical therapist who went through a standardized program where they spent about half the time on education, depending on what group they were randomized to, and half on a progressive tendon loading exercise program. And then we evaluated them again at 8 weeks. And then at 12 weeks, we had like an online only evaluation with just some surveys. And for the results, we found that both groups had a decrease in pain, so about a 3-point decrease in movement evoked pain, and that specific to like Achilles tendon function, that both groups improved. So it was like a 20-point improvement on the VISA-A and an improvement in the number of heel raises they were able to do. And in addition, both groups had a decrease in their fear of movement and pain catastrophizing. So what we found, thinking back to our hypothesis, was that, we didn't find that adding pain science education to a best care exercise program for AT didn't like enhance the improvements in pain and function as we had hypothesized when compared to adding a biomedically based education. Then we had some secondary hypotheses to look in to see what were the factors that were associated with a greater improvement in pain and function. And we found that those that had the greatest improvement in self-efficacy and those that had the greatest increase in knowledge about Achilles tendinopathy had the greatest improvement in pain and function. And so this leads to an idea that, potentially acquiring skills for self-management of symptoms and the process of learning may be more important than the specific content of the educational approach.
And the findings that you noted, actually, they were challenging my biases, I suppose, when I consider, a lot of times we see a lot of these studies that show discussing pathoanatomy and discussing these bone spurs and discussing these disc degenerations, that actually makes symptoms worse, that actually makes outcomes worse. So there's been, in my perception, a change in our profession away from talking about the pathoanatomy and talking about this biomedical kind of approach to education towards more of a pain science approach and towards more of an understanding of what's going on, maybe not as much from a tissue level, but from more of a perception symptomatic level. And this study kind of showed that maybe that's not as true. Maybe our perceptions on what's effective and what's not effective, maybe that's not as accurate. And maybe it's knowing more about what's going on is what's making the big difference, as you mentioned. And so in that way, if we're going to challenge our biases in knowing maybe one intervention might not be more effective than the other, I guess, do you have a perception on where you would start? Like what are some factors that might make you think this person might benefit more from a pathoanatomical discussion versus this person might benefit more from a pain science discussion? I guess from your experience, if you had to choose, somebody came in with Achilles tendinopathy and you wanted to talk to them about what's going on, which kind of end of that spectrum would you kind of lean towards to start into?
I think that one benefit of clinicians versus researchers is going to be the utilization of the patient subjective, and picking up on little cues from the questions that you ask a patient and the follow-up responses that you receive to really inform and drive your clinical decision making on where to start with either a pathoanatomical or biopsychosocial approach to the patient, and really utilizing that to frame the content of your education that fits within the context of your patient's understanding of their diagnosis, and so specifically Achilles tendinopathy. And so from the data that we gathered, we saw that enhancements of the participants' knowledge, whether it were pathoanatomical or those individuals in the biopsychosocial group, that those enhancements of knowledge were associated with improvements in symptoms and function. And I think one caveat to that was that regardless of the group, either whether it was pathoanatomical or the biopsychosocial, we incorporated the most current and the highest level of evidence for the pathophysiology of Achilles tendinopathy, or the most current and highest level literature for how to complete a biopsychosocial approach. And we also incorporated high level evidence into the instruction how to complete the exercise program for symptom monitoring, monitoring for progression, and activity modification. And so it might not be one is better than the other. It may just be kind of picking what fits best for your patient, kind of what they're telling you along the way, and kind of informing you on where to start. And I also think that one thing is I would emphasize kind of using that information on where to start, because it may change along the course of care. So as clinicians, we know that the plan of care changes along the way. And so as you continue to develop your relationship with your patient and you have the open communication, you may pick up on other little bits along the way that may inform you to switch from having your biopsychosocial hat on to then having to put your pathoanatomical hat on and switching back and forth. And so seeing that both enhancements in knowledge in both pathoanatomical and a biopsychosocial approach for education fits, having that capability and those tools in your toolbox to flip back and forth may be beneficial to your patients along the way.
Hey, Andrew, I'm curious because I remember you talking about how, you were kind of set in terms of what approach you had to take with the participants. But I know you also had biases where you were like, oh, this person, I wish I could have taken the biomedical approach, or this person, I wish I could have taken the pain science approach. Like, I guess I'm just curious, like, kind of what percentage of patients do you think fell into each of those buckets where you thought it should have been one approach or the other? And what prompted you to decide one approach versus the other would have potentially been better?
Sure. Yeah, that's a good question. I would say that the individuals that I felt were the randomization to either the pathoanatomical or the biopsychosocial group, it were the individuals that were randomized to the biopsychosocial, where it may not have been a good fit for their personality in the education group. I think there's also literature within the whiplash literature where individuals in the psychosocial group are referred to psychologists, don't really feel like that's necessarily needed for the condition that they have. So I felt like my perception I'm picking up, and there's no way to quantify that, was just that the individuals that were allocated to that group, that may not have been the best fit, more so versus the ones that were in the pathoanatomical group.
As we're talking, it reminds me exactly of that. I think it was a clinical commentary from maybe 2015 in JSPT. It was like one size doesn't fit all when it came to tendon loading. And as we know more about exercise, we know there's different ways to get somebody back to what they want to do with less discomfort. And as we're talking, it doesn't seem like it would be any different for any other intervention, is that there's no standard protocol for everybody that comes through the door, but matching what you're doing to what the patient needs obviously is going to be helpful. But then to get started into how do I select what intervention is appropriate, this is always where I have a challenge with research, is because I like what you all did in the sense of having multiple interventions, because I think that replicates clinical practice and that can be more easily tied into taking the findings from this study and applying them to the people I see in clinic. But as we know, when you have multiple interventions, it's hard to figure out what caused the effect if one was more dominant versus another. And as you mentioned in your discussion, exercise, we know, tends to be pretty helpful in a lot of cases for tendinopathy. And this exercise program was actually applied to both groups. So what are your thoughts on these more kind of clinically relevant approaches to research studies, where this is what would be done in clinic, but we can't really determine what the discrete effects are of each of those interventions? And maybe if there was like an education versus exercise versus education plus exercise treatment arm, that would help us maybe get more information on the discrete effects of an intervention, but maybe move away from clinical practice. I'm just wondering, what are your thoughts on trying to break it down to these small, discrete activities with fewer confounding variables that kind of move us away from clinical practice relevance a little bit?
Yeah, no, I think, okay. So I actually want to comment back on your first point that you made about the one size doesn't fit all in terms of loading. I thought that was a great point in terms of, there were a lot of different exercise programs. Like, it used to be like, oh, you have to do eccentric exercise. And they're like, oh, okay, or you could do concentric too, or you could do heavy, slow load. So anyway, so I like that we have that flexibility now. And I think that one conclusion from this study could be that, okay, well, as physical therapists, we also have the ability to personalize our education approach as well. The results did not fit, my biases going into the study, but I do like that it does support taking an individualized approach to education. So it's not like there's just one way to do education as well.
Sure.
So,
Sure.
yeah. And then also for your second question, so we know that, exercise plus education is effective for Achilles tendinopathy pain, and that's great. It would be interesting to know, was this effect primarily driven by the exercise, or did you have to combine it with the education to achieve this level of pain and function? So, it could be like, in terms of the exercise, like we had like a third arm where it was just like a 10 to 15 minute visit, exercise only. I do wonder, would you have gotten that same reduction in the fear of movement and the pain catastrophizing that we saw in the pathoanatomic education group? Because I think one thing that makes this program, Exercise for Achilles Tendinopathy, a bit unique is that it's this progressive tendon loading program where we start them with isometrics, where they're starting to engage in exercise, with a kind of like a low threat, because with isometrics, they really don't have much pain and they're learning to load their tendon. And then we progressively take them into these exercises like heel raises and hopping that people have more fear of movement with. And it's a bit different because there was a meta-analysis published by Sadal in Pain in 2021 that showed that pain science education plus exercise was more effective than exercise alone. And this was for a variety of chronic musculoskeletal pain conditions. But I think that this progressive loading program for Achilles tendinopathy is more of a graded exposure approach, whereas, your typical therapeutic exercise for low back pain would be a different approach. So yeah, I'm not sure if it's, this specific type of exercise program is equally effective for the psychosocial factors, or if that, really just like washed out the effect of education. But then again, we also have information about the change in self-efficacy and just change in knowledge was associated with improvement. So, maybe it was due more to having a physical therapist who was skilled at developing a strong therapeutic alliance and dedicated 10, 15 minutes talking with someone about their condition. And that led to the change. So yeah, I know you answer one question and then develop more questions.
Well, that's the good thing about research too, then, is one question leads to another question, and we'll never have all the answers, but that's, I think, one of the benefits of doing studies like this is finding more questions, Yeah. But then one of the things you actually measured using this study design was something called conditioned pain modulation. And so I think a lot of people know about conditioned pain modulation from a lot of research studies in pain, but I don't think it's actually done that much in clinic, and I don't think a lot of people assess it in clinic. So I'm wondering if you all could maybe just kind of briefly describe what conditioned pain modulation is actually looking at from more of like a physiological perspective, maybe how we could potentially replicate conditioned pain modulation assessment in the clinic, and then maybe what you found from this study in terms of conditioned pain modulation, what that means in terms of people with AT.
Sure. So that's a great question. I think we were interested in looking at the descending component of an individual's pain experience. And so you can break down pain in a few different ways, and part of it can be the ascending component. So the pain signal, nociceptive signal that's coming from the Achilles tendon up to the brain, where it gets processed, and also the descending component where there are signals coming from the brain back down to the body. And that can also be divided into an inhibitory component or facilitatory component. And oftentimes there's a balance between the inhibition and the facilitation. However, it's believed that individuals that have chronic pain conditions may have a shift in that balance towards either inhibition or facilitation that continues to perpetuate or contribute to the chronicity of the condition. And so we were interested in looking at the way that individuals that have chronic Achilles tendinopathy are able to inhibit pain. And so the thought process for the assessment of conditioned pain modulation or diffuse noxious inhibitory control you may hear in more animal or benchtop articles is with the application of a noxious stimulus to one area, and then you apply another noxious stimulus to a remote or distal area. And the idea is that the greater of the two evils will cancel out the other. And so our thought was if we applied a painful stimulus to the Achilles tendon or somewhere close to that, and then applied another painful stimulus in another body area, that we may see changes or dysfunction within the ability of the individuals to inhibit pain. And so we completed pain pressure thresholds at the Achilles tendon with an algometer. And we also looked at the hamstring tendon as well. And then for our neutral stimulus, so the non-noxious stimulus, we had the individual put their hand into a bucket of water that was at room temperature. And then completed the pain pressure thresholds. And then to apply our conditioning stimulus or the noxious stimulus, we had the individuals put their same hand into a bucket of ice water, cold water that we maintained at 6 degrees Celsius. And we also then reassessed the pain pressure thresholds. And what we found was that the conditioned pain modulation did not change over the course of their enrollment. So from baseline to the primary endpoint at 8 weeks. And so for your last question of what are the clinical implications of the findings, kind of to refer back to what you had mentioned earlier of kind of enhancing clinicians' understanding of why what we do works or helps out. Because we didn't see any changes in the CPM, it's possible that the alterations in CPM may not be the mechanism through which interventions like exercise or the education intervention that we applied, that those interventions work through that resulted in the improvements in pain and function for individuals with Achilles tendinopathy. Again, that's just what we saw in ours. There may be individuals in the clinic that does change, but from the data that we saw, we didn't see any changes there. And you'd also asked about how to improve, or that it's not measured very, very frequently in the clinic. So the way that we went about doing this, it required actually two people. One person do the pain pressure thresholds. The other person was maintaining or monitoring the temperature of the water. We had a thermometer to maintain a constant temperature of the water. We had something that was circulating the water along the way. We also had additional ice on hand to maintain if we needed to decrease the temperature after the participant put their hand in. And so balancing that in a clinical setting may be challenging to find the resources and the time to do that. There's also other components, including the need to evoke a painful response in another body area. And so if clinicians feel comfortable doing that or not feeling comfortable doing that, that could also be another barrier to completion of CPM in the clinic. And so it's kind of weighing out the pros and cons, feeling comfortable what the patient would feel comfortable doing, and if you have the time and ability to set that up in the clinic. I do know that there are clinicians that do assess CPM. And so I think if you can find ways to be efficient with doing that and you feel comfortable, I would never want to deter anyone away from doing that. I would also actually encourage them to, because they would then be contributing and be kind of on the forefront of clinicians and other researchers that are continue to assess this component of pain within these clinical populations. Kind of conversely, if we were finding that it's cumbersome or requires quite a bit of setup in the laboratory, there are clinicians that are finding ways to do this that are more efficient and more simplified down compared to what we had to do. That may just be more speaking towards the need for researchers, us in the laboratory, communicating and finding ways that clinicians are able to do this to enhance the methods that we're doing to increase the similarity, which then ultimately would have impact the overall interpretation of what we're finding and the generalizability of our results.
Speaking as a clinician myself, I can see the benefit of doing CPM in the clinic, but just logistically, it actually is kind of challenging, which then comes back to if I can't do it in clinic, or if it's hard to do it in clinic because of the time and resources, then I have to use the research that's available. And this research can be extrapolated because of the well-performed randomization here and the well-performed placebo-controlled interventions. But then it kind of actually, as you were talking, it kind of brought me back to the point we're making in terms of the outcomes based on the interventions. Part of me wonders, with some of these studies, we see improvement within the 12 weeks. And sometimes these protocols for tendon loading, they last for about 12 weeks. And so we typically know that people will get better in some capacity and during that time. I think one of the challenges I have is how much better are they going to stay after this study is complete or after I'm done with them in the clinic? They've gotten better, their visa A is much improved, they're not complaining of difficulty doing their activities. At what point do I wonder, are they going to stay this well, or do they have to do some sort of maintenance? I'm wondering, do you think the outcomes would have been different had you tracked people over time, maybe like a 6-month follow-up or a 12-month follow-up, or if that's really even logistically feasible for some of these types of studies?
That's an interesting question. I think, in general, a lot of times people think about the recovery pattern for Achilles tendinopathy in that you really wouldn't know if exercise intervention was really effective until maybe like 6 or 12 months. So you'd want to give it a longer period of time before concluding, yes, this was the intervention for you, or no, let's proceed on to the next step in care. I think that for this study, if we'd continued on to have a longer follow-up, I don't think we would have really necessarily seen a difference between groups in terms of pain and function. They'd probably just, both continue on, kind of probably like a slow plateau going on with that. But I do wonder about some secondary outcomes related to their use of healthcare. So this is purely anecdotal, but at the same time that we had this clinical trial, we also had another study ongoing where it was looking at the effectiveness of a minimally invasive procedure called 10X for Achilles tendinopathy. And so the patients who enrolled in TEACH, and then you were also enrolling for this other study, and we continued that enrollment about a year after TEACH. So we had, I guess, informally kind of like a year follow-up for everybody in the study. And over that time period, we saw there were 4 people who crossed over and progressed onto having a minimally invasive procedure. And 3 of those were from the pathoanatomic education. And so, I mean, it's a very small effect.
Sure.
And anyways, it's a small thing, but it does make me curious about the long-term implications of the education that you provide to patients on the source of their pain. So, we're telling patients, we think that the primary source of your pain is coming from these biological factors. It makes sense that in the long run, if they continue to have pain, they'd seek out a procedure that would be removing that pathology. So yeah, I am curious to see what their long-term uses are of healthcare resources and, to see what other things they seek out.
Yeah, and I personally believe that's actually one of the under-assessed components of research is the secondary utilization of additional healthcare dollars. Is you got better or you got to this point, and then what? So those follow-up studies would be very interesting. But Obviously, one of the goals is to try to reduce the amount of healthcare dollars spent and reduce the resources spent and reduce the need for healthcare practitioners and try to improve self-efficacy, which happened in this study. And one way to do that is actually through virtual telehealth visits. And that's actually what you had to move to, it seems like, based on being right at the height of COVID, not being able to get people in to see you in person. And so you had to do some telehealth. And that kind of led me into thinking, could we do these education interventions without having people come in and have to pay for parking and have to take some time out of their day? Could they just be doing these things in the middle of a work day or whatever it might be? I'm wondering, what do you think are the potential benefits or even limitations to try to do more education, specifically with Achilles tendinopathy, but even in painful musculoskeletal conditions where we're talking to people over the computer or even talking to groups virtually? Do you think there's a benefit to that, or maybe what are some drawbacks to that in that construct?
Right. Yeah. So we started recruitment in the fall of 2019. And then when the COVID pandemic hit, Ruth and I were able to spend our spring break transitioning everything over to telehealth. And there were certainly benefits of telehealth that we found from our ability to enroll individuals in different manners and provide the intervention through different formats. We ended up having 3 different groups. We had an all in-person group that we had from the beginning of enrollment to the beginning of the pandemic. And then we had an all telehealth group from the beginning of COVID until we were able to open back up and begin in-person human research again. And then after that, we had a hybrid group where we offered both telehealth and in-person visits where individuals were able to complete either all telehealth or in-person or a combination of the two. And we were able to compare those 3 groups. And we actually, interestingly, we didn't find much difference between those 3 groups for outcomes related to pain, function, the psychological variables as well. And one item that we kind of argued is if we can show that telehealth or a hybrid format isn't any worse than an in-person, what we can kind of start doing then is potentially proposing that we can incorporate the patient's preference into how they complete their visits. And so kind of like you were saying, they don't have to pay for parking. They don't have to worry about carving out time in their day to come to the physical therapy visits. And then an additional benefit would be providing exercises within the context of their own home or their daily activities, and working those exercises into their normal routine. And so we had individuals during telehealth that were in the telehealth group that said, this is great. I can do this while I'm brushing my teeth in the morning. I found ways to do my exercises while I'm making breakfast in the morning. And I can just roll out of bed and log on to these appointments and log right off and get back to doing other things. However, there are some potential limitations with telehealth that we found. And so one of them, we don't really know who is best for telehealth or what diagnoses are best. And so we might need a bit more data to kind of figure out which diagnoses or unique patient characteristics are appropriate. And another potential limitation for telehealth would be the ability to directly screen a patient. So if someone has an uncontrolled cardiovascular condition that we may be leery of initiating an exercise program with, we're not able to take things like vitals or screen for any other red flags that may preclude their ability to participate.
And one thing I just want to note is that as Andrew was talking about comparing the in-person versus virtual delivery of the exercise and education, that he wrote up a paper and it was just recently accepted to PTJ, statistically comparing the different groups. So I just wanted to note that will be coming out soon.
Oh, nice. A teaser.
Yes.
Awesome. Well, congrats on that. I have to take a look at that. That's going to be interesting to see. But as we're kind of talking about that, and as we're kind of talking this entire session, what we're seeming to kind of conclude is that there's no right answer, right? So there's a lot of good answers, and maybe there's better answers for certain things, but there's no one answer for everybody. And that's always going to be the case, I think, in our profession. But there's a ton of research actually out on Achilles tendinopathy, a lot of high quality research out there. But as you all noted in your introduction, and as a lot of people see in clinic, a lot of people with Achilles tendinopathy, regardless of best practice, they just don't get better or stay well. And up to 50% of those people don't get better or stay well. So I'll kind of leave it with this question for both of you, is I'm wondering, based on this study or just in general from your clinical practice, your expertise in this field, why do you think there's such a high proportion of individuals that are not getting better or staying well? What are the gaps that we're missing in our current research, and how do we suggest filling those gaps, whether it's from a research perspective or an education perspective or a clinical perspective? Like, what do we do about this problem, and what are the problems that exist?
Yeah, so I agree. I think, a major strength of the literature right now is that exercise is like the most evidence supported intervention for Achilles tendinopathy, which is awesome. Like better than any other like injection, surgery, like exercise has the highest level of evidence. And that's great, but we still know that exercise still doesn't work for everyone. And part of the issue is trying to see, when do we progress from exercise to an invasive treatment option? And right now, several recommendations say that you should wait 6 months to 12 months for that. And part of that hesitancy in terms of when do you progress on is that there's a lack of research supporting the effectiveness of these invasive procedures. So we don't know, is the risk of complications with an invasive procedure worth the potential benefit of progressing on? And of course, we don't want to have somebody who has a single flare-up of Achilles tendinopathy pain and then directly advance to surgery or anything like that. But it does make me think about, those athletes where they have a decrease in function, like a decrease in function for a year could change the course of their career in a sport, or someone who has a consistently high level of pain that interferes with daily activities that could really disrupt their quality of life. And so trying to figure out who are the people that I think, still, everybody should start with exercise, but who are the people that you would want to advance sooner into another care option? And I think that the advances in terms of precision medicine for knee osteoarthritis and low back pain that take into account differences in potentially psychosocial factors, activity level, type of pathology, genetics between individuals in order to select a treatment that best works for them. And so I guess one of my long-term research goals is to try to figure out which factors are most relevant to consider when making decisions about care for Achilles tendinopathy, and try to improve people's outcomes, and then also make sure that it's done in a timely way as well, so you can shorten the duration of disability.
And I would agree, very similar to what Ruth said, identification of prognostic factors for individuals that might not respond well to an exercise program and then require other possibly invasive interventions, but also identification of potential resiliency factors with those individuals that do or have the potential to positively respond to conservative interventions, and kind of utilizing or leveraging those to become more efficient within the physical therapy profession, potentially triaging those that we know or have the potential to positively respond versus those that it's worth maybe giving a try, but then knowing that those are the folks that maybe might progress on to more of an invasive procedure like Ruth was talking about.
Yeah, and to be able to do that, obviously you need to have evidence to support those other potentially more invasive procedures versus what we're doing, but then be able to just have a conversation with the person that's in front of you and be able to identify what those variables are that make someone more appropriate for one intervention versus the other. But kind of taking a step back, it seems like we have a lot of good answers from this study that you all did to show that, let's put a pause and hit the brakes on our biases, because maybe what we think is more effective maybe isn't what the patient or the person that's in front of us wants, maybe is the most appropriate thing. But there's still a lot of questions to be asked and questions to be answered. And I'm looking forward to a lot more of your research to be published to be able to do that, to guide our clinical practice. So I want to take a minute just to be able to say thank you for taking the time to chat with us today, Drs. Chimenti and Post. And I know the listeners had a really good opportunity to engage with this article and the content that came from it.
Great. Well, yeah, no, I really enjoyed getting to speak with you all. And yeah, thank you. Thank you for having us on.
Yeah, it's been fun. Thank you for inviting us.
This has been a production of the American Academy of Orthopedic Manual Physical Therapists. You can learn more about the Academy by visiting our website at aaompt.org. You can also find us on Facebook, Twitter, and Instagram by searching for our acronym, AAOMPT. The views and opinions expressed on the AOMT podcast are those of the interviewers and interviewees and do not represent the official position of AOMT. The information presented should not be used as personal healthcare or clinical practice advice. If you need to find an expert orthopedic physical therapist near you, then check out the Find a Fellow feature under the Public Resources tab at www.aaompt.org, which you can find in the show notes.